You're listening to the Assembly on Sleep and Respiratory Neurobiology podcast, brought to you by the American Thoracic Society.
Hello, welcome to the Sleep Pioneers podcast. My name is Elena Shotland. I am the co-chair of the ATS SRN Web Committee. Today, I have the pleasure of speaking with Dr. Barbara Phillips. Thanks for joining us, Barbara.
Thank you. It's really a pleasure.
To get us started, I would like for you to first tell us a little bit about your background and education.
Thanks. I'm a public school kid. I went to school in Kentucky, which is where I grew up and where I now live. And then I compounded things by going to college in Mississippi and then came back to Kentucky for medical school. At that time, medical schools had this strange notion that if you confined your matriculants to in-state residents, that might increase the number of doctors in your state. That, of course, has turned out to be totally false. And after I graduated from med school in Kentucky, then I went to what was then called Medical College of Virginia, now called Virginia Commonwealth University in Richmond for pulmonary fellowship, which at that time was 2 years. I then came back to Kentucky, and frankly, mostly because of my partner. He is a Kentuckian, and I am too. And so we came back here and joined the faculty at the University of Kentucky, and that's the rest really is history.
So how did you get interested or involved in sleep?
Like so many things in medical education and probably life, it was mentorship. It was not my interest. As a very green pulmonary fellow at MCV, now VCU, we were told to try to find some research, try to get involved in some research. So perhaps the most approachable guy on the faculty, Kevin Cooper, was a person that I sought out, and he said, well, I think I'd like to try to set up a sleep laboratory, and you can help with that. Do you know how we can get an EEG machine? And it kind of went from there. We did get an EEG machine that we borrowed part-time sometimes, but nobody really knew how to hook it up or how to read EEG. But we had it. But the sleep lab at that time was initially based in the P lab. And so we rolled a hospital bed into the PFT lab where we could hook up an oximeter, an ECG monitor, and measure airflow. And we did, I wouldn't even call them nap studies. I'm not sure that anybody ever went to sleep during these, I'm going to call them recordings, for lack of a better word. And we did observe the things happening to people's breathing when they were ostensibly asleep, but who knew if they were asleep or not in the day. However, most of them were house officers who could sleep anywhere, anytime if they're given permission to do so. So there you go. And I'm not sure it went any further than that. I don't know that Kevin and I actually ever published anything. Although we might have, I could look that up to see. But Kevin was the very best kind of mentor because he was available. He didn't pretend to have any knowledge of stuff that he didn't have any knowledge of. And he just put stuff in my lap and expected me to work it out, but was very encouraging about it. So that worked quite well between us. And I really appreciated that. 2 years later, when I got ready to go back to the faculty at the University of Kentucky, somebody said, oh, I see you've had some experience with a sleep lab. And I said, well, do you think you could just set up a small one here, just like a research sleep lab? And so once again, I teamed up with who have been my best buddies, mentors, friends, and teachers throughout this entire process, which is respiratory therapists. And we did set up a sleep lab, and we recruited a neurologist who brought in a tech to hook up EEG leads and then read the EEGs for staging of sleep afterward. But these were all just kind of research studies. I don't even know what happened with them. Every now and then a advanced internal medicine, this is happening in 82, 83, and 84, right? So a while back, an advanced internal medicine resident would say, hey, I hear y'all got a sleep lab. I got a patient I want you to study. And so they would bring them in a wheelchair and we'd hook them up and do a 2-hour nap study in the middle of the afternoon. And I'd go, yeah, he does have sleep apnea. And we all went, oh, how very interesting. And as far as I know, other than advising the usual things, lose weight, quit smoking, of course, at that time, everybody smoked in Kentucky. We didn't really do much with these, but over time, and of course, nobody got paid, by the way. No insurance was billed, nobody got paid, including the PFT labs techs who worked extra to do it, or the neurologists who, Robin Gilmore and Yvette Cook, who were so helpful to me and supportive. They didn't get paid either. We just all did it kind of out of interest. But over time, with the help of now probably the most important PFT tech, and that's saying a lot. I mean, there have been a lot of pulmonary function technologists who have really made big differences for me. And everybody in my sleep lab when I retired was a respiratory care practitioner. Everybody. That was the criterion to be in that lab. But anyway, Tom Keener at that time was the respiratory therapist who was most interested in this. And he did things like put fangs on top of oxygen cannulas so that they could be used to sense airflow at the nose and the mouth. And, you know, he could make things. And so we did have a pretty full sleep lab. We didn't measure limb movements or peripheral movements, of course, but it was good enough. And we were sometimes getting end-tidal CO2, sometimes not. You know how that goes. And eventually, and I'm not even sure how or when this happened, we started billing and getting reimbursed very small amounts for sleep studies. And gradually over time, we became one of the first accredited sleep centers in the US, and it grew from there.
What would you say is of which achievement are you most proud?
Honestly, I think that being involved in the leadership of CHEST, with whom we at ATS, of course, have a very friendly but competitive relationship, but being on the board directing much of the sleep education for CHEST, being ultimately president of CHEST, and the things that we were able to do for CHEST as an organization, but in particular to bring pulmonologists into sleep medicine, which of course is where they belong. Was very important to me.
What brings you the most joy professionally?
Well, you know, I've been retired for 6 years. This is the first even semi-professional thing. Well, I had a neighbor that came over the other day to want to talk about her sleep paralysis, but I don't, it's been a long time. When I had a long profession of 36 or 37 years. And I think the things I really liked were teaching rounds with students and residents, honestly, bedside rounds. And that didn't happen in the sleep lab. That happened in the ICU, right? In the sleep lab, you don't have that many mentees, although we did have for a short period of time, you could get accredited board certified in sleep medicine if you trained with somebody that was board certified in sleep medicine. So I had several of those trainees, and that was also very fun.
What brings you the most joy personally?
I would have to say it's a tie really between kayaking with my golden retrievers and swimming with my golden retrievers. But I hike and creek walk and compound hiking with things like hunting for things, hunting for, in Kentucky, arches. We have, according to Utah, the second most number of arches in the country. We think in Kentucky that we actually have the most. They're just not documented. But I'm working to help document arches here in Kentucky, but also to find the old iron furnaces and the dwellings that surrounded them. This is all in the context of hiking in the Daniel Boone National Forest, or maybe in southern Illinois as well, and also in the land between the lakes, mostly locally.
Mm-hmm. How did you keep up your career momentum?
I think, and this is not necessarily a good thing, I think if you put yourself out there, if you are at the podium and you do a good job, somebody sees you and says to their group, ooh, we should consider inviting this person. And you go there and you do a good job. And that expands the numbers of peoples and groups that you can work with and your reputation, and it gives you momentum, and it also keeps you fresh. You're not going to trot out the same talk 6 months later. You're going to go back to the literature and upgrade it. And I think people need to know and want to know that you're you're tailoring what it is that you're saying to them for them. And I think that's pretty key. It didn't hurt to get divorced. That enabled me to be gone more, travel more, do what I wanted to do more. I don't regret that, actually. And it also helped that I was in an academic institution, and as long as I made my salary and whatever was required, they kept a pretty loose rein on me. And so I had that freedom.
Is there anything you would have done differently?
I think I would have been more assertive, and this is a different topic for a different group. But, when I was starting out, women in medicine were not as common as they are today, and we very often ended up doing things like this, directing the ICU, which I did, in addition to everything else, the director, 7 a.m. Meetings, making suggestions like we need to get hepatitis shots for the nurses, which were ignored, by the way, for nothing. That's just part of your job. And then when you finally quit because you got a full-time sleep lab and a grant and you're running this program and the TB, and you just can't do it anymore, they hire a guy for $10,000 a year. So I wish I had, it would sound really kind of bitter if I told you a dozen or so examples of that. Plus, we need to talk about more important things. But I wish that I had perhaps been a little more assertive, or in male speak, aggressive.
If you had not been involved in sleep, what do you think you would have done instead?
Well, I loved pulmonary medicine, every single part of it. I mean, I would have been a pulmonologist and there's so much you can do, right? I mean, I was involved in TB control and education for a while, which I really felt was important. And not only that, it's addressing an age-old problem that keeps coming right back at us, and it's going to swing back around again. I can predict that now. I also ran the ICU and spent more than half of my professional career working in the ICU, and I liked that too, very much. I liked the collaboration with nurses and doctors of other specialties and also medical students and residents. I wasn't always proud of the things that were done to patients that were clearly dying to appease somebody. That was the hardest part of ICU for me, and I didn't miss that at all. And I suspect it's not quite so bad now.
What are the biggest technological innovations or changes you've seen over the course of your career?
Smart CPAP, right? I will say it amazes me that you still can't get a CPAP machine without a prescription, and you can't get a prescription without a sleep study, right? I mean, CPAP is safer than aspirin. To quote the founder of ResMed, the only way you can hurt yourself with a CPAP machine is if you drop it on your foot. And that was 30 years ago when they were much heavier than they are today.
Yeah.
I mean, I personally think that people ought to be able to go buy CPAP machines over the counter at their friendly local drugstore, put it on auto and let it figure out what they need and go from there. This whole business of requiring a sleep study for somebody who has witnessed apneas, hypertension, obesity, coronary artery disease, and all the rest of it in your waiting room is ridiculous. And of course, we all know why we do it, right? It's the money. I guess I got a little off topic. Let me answer the direct question. Smart CPAP that I feel is totally safe and should be prescribed auto titrating 8 to 15 for everybody. And then you can download it and set them at what they need, or not. That's okay too.
What do you think are the biggest challenges for the field?
Well, one of them is trying to release the stranglehold that sleep centers have over the treatment of sleep disordered breathing. Another is trying to combat what I really think is the overuse of uppers and downers. Hypnotics, we know they're overused, and we know they're associated with bad outcomes in the long run, including things that affect others, like car crashes. And then, of course, alerting agents, stimulants, whatever you want to call them, are also, I think, overprescribed and overused.
What advice would you give people who are new to the field?
Find a mentor / partner. And your mentor, if you're a woman, your mentor doesn't have to be a woman. A man is just as good, maybe better, because they may have more contacts than you. If you're a doctor, your mentor doesn't have to be a doctor. In fact, my best collaborator was a PhD in psychology, for God's sake, David Berry, PhD. And we didn't really do much psychological research, but what he knew that I didn't was statistics, how to do statistics, how to look at data and go, that's just noise, or this is the truth, but we need 1,000 more patients to prove it. And so find a mentor or a partner, and that is all about chemistry. It has to be somebody that you trust and who trusts you. It has to be somebody that'll give you just enough rope, but not let you, hurt somebody or yourself. But you need a mentor, and you need to spend time with that mentor. I think that would be, and do what interests you. I mean, it's all interesting to me. But if you find a mentor that you have chemistry with, and what they really want to do is count microarousals or something that makes you just want to have a big sleep yourself, maybe you could talk that mentor into doing a project with you that's of your interest.
Thank you, Barbara Phillips, for joining us today. It was a pleasure.
It was my pleasure too. I could go on for a while. I think you covered everything though. And thank you for the way you organized this to
Oh, you're welcome.
to send can I say one other thing though?
Oh, of course. Absolutely.
We as a group, sleep specialists, need to be more vocal and more cohesive about this switching times back and forth. We left daylight savings time again, and right now we're slated in March to jump forward again, and it's crazy. And not only is it, disturbing and disruptive, it kills people, right? We know there's an increased crash risk the morning after we move the clocks forward. We know there's a huge cost involved with this. There was a bill that passed the entire Senate, Marco Rubio's bill. I think it was called the Sunshine Act. And of course, it went to the House where nothing happened. I suspect that part of the reason that nothing happened was, I think there was some, when the experts were asked, they said, well, this bill is no good because it wants us to be on permanent daylight savings time, and we know that that's worse for you. Well, we don't really know that. There was very little data about that. There was, however, a pretty bad experience with it in, I think, 1980s when it was quickly repealed. But even permanent daylight savings time would be better than switching back and forth twice a year. But what we need to do is get on the same page and push. Don't make them come to us. We need to go to them, to the legislators, and say, this was a good idea that Rubio had. We would really like to support it, and it would be better if it were standard time. But anything is better than switching the clocks twice a year.
Thank you for joining us today. To learn more, visit our website at thoracic.org. Find more podcasts from the ATS assemblies on YouTube. Don't forget to like, comment, and subscribe so you never miss a show.